everybody, it's Dr. Roth. This video is actually for SLP 510, Articulation and Phonology. So we are already in topic 6, but I wanted to just kind of pick up now that we know we kind of like these little mini lectures. I was just going to hop right into topic 6 and talk about a few things that we're doing. But what I will try to do is between the two courses, I'll try to do at least a little mini lecture for each, maybe not every week, but for each topic. So for topic 6 and 510, we're talking about summarizing and classifying speech sound disorders. So this is, their objectives are identifying phonological patterns in a speech sample, also determining differential diagnosis on collected data. And again, since we're in articulation and phonology, we're going to be focusing more on those kind of speech sounds and not really thinking about language in this course. Although technically, phonological disorders are language-based. We're still thinking about it in how it sounds rather than the structures of language. Okay, so it can be divided into two main components. Speech sound disorders can be divided into two main components. Phonetic, which is articulation disorders, or phonological, which are the phonological disorders. So our phonetic articulation disorders are going to be those disorders where the child is consistently having a motor-based issue producing the sound. So that's like when we get like the lisp, like they literally cannot say the S without putting the tongue through the teeth. So that is a true articulation-based disorder because they physically are having difficulty doing it. Phonological disorders, this is, even though I said we're not talking about language, this one is technically considered a language-based disorder because they are kind of violating the sound system and rules of language. So while they might be able to say a certain sound, when they actually try to put the sound into speech or language, that's when you see the error occur. So I actually have a family member who had a really cute phonological disorder where he was doing backing, which means he would move his sound back. So he could say the letter, but not produce it in a word. So he could say his D's, but anytime he tried to use it, his D would turn into a G. He would move that sound back. So his mom would try to work with him, and he would go duh, duh, goggy. So he has the ability to physically make that D sound, which kind of rules out our thinking that it's an articulation disorder. But since he kind of moved it to that back placement, that's now making us think, okay, this might be more like a phonological disorder. And that type of error is actually called backing. So just a little overview of the types of disorders that phonological disorders you can have. You can have final consonant deletion, and I won't go over all of them, but I'm just trying to give you an example of the different phonological disorders. So final consonant deletion. So this is when they leave off that final letter. So for example, a child may be able to say the word T, but when they go to say cat or mat, they might say ka, ma, and just drop it off. So that's that kind of phonological process. Another way that you can tell the difference between articulation and phonological disorder is that the articulation disorders, it is the letter itself that they tend to struggle with, and that's going to be that same letter every time. But with the phonological processes, the type of error is the same, but the letters might change. So if they have final consonant deletion, they're going to drop off any final letter, right? So if it's cat, it might be ka. If it's map, it might be ma. If it's ball, it might be ba. So those are all different letters, but the same thing is happening. That final consonant is being dropped. That's another little tip for phonological process. Cluster reduction, they might, this is common in little ones, but when it kind of extends past a expected amount of time, that's when it kind of starts going to that phonological disorder category. But they simplify words. So instead of saying plain, they might say pain, dropping that L. So what they're doing is they're kind of simplifying the word. Or I'm going to make one up, but like instead of saying school, SK, they might say, I'm going to school, because they're simplifying the word. They're reducing that cluster. They're, instead of taking 2 or 3 consonants at a time, they're just doing 1 consonant and straight into the vowel. Let's see, it's another, I'm just only going over the common ones just to kind of help you guys understand the concept. One, fronting, we already talked about backing, but fronting is when you move a back sound forward. So instead of saying that k, that cat, which is that back sound in the kind of velar position, k, 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 our tongue is really far back, they're actually going to move it forward. So it's going to be tat. And also what you'll see is these sounds are kind of in the same position. So we wouldn't move it to like cat to mat. That would be a different one. It's just you're moving the tongue just a little bit forward. And that's why it's called fronting. We're just fronting that tongue. Cat for, or tat for cat. Another one is stopping. So this is when you're going to get a fricative, like a s or and you're going to stop it. So sun, when we stop an S, it turns into a T, ton. So instead of saying the ton is bright today. And there's many, many more we can go into, but that's the difference between phonological and articulation disorders. Etiologies can be different. So the causes can be different. It can be a functional disorder, which means there's no known cause, or it can be organic, meaning something else kind of physically caused it, such as like hearing loss, structural or abnormality, maybe like a palatal issue, a tongue tie. It could even be a brain-based disorder. So that would be kind of more in that organic category. I'm just kind of looking here, make sure we're not missing anything. Okay, so it's important to know whether you are dealing with an articulation or a phonological disorder because you are going to treat them differently. So for articulation, since it's a motor production issue, we're going to use motor-based disorders. It's still brain training, but it's brain training that kind of motor cortex. So for example, we do things like draw their attention to our mouth and make sure they really see what we're doing. We might do co-speaking, where we look in the mirror and we talk with them to kind of help use their kind of mirror neuron, motor mirror neurons. Like we kind of assist them by being like, mom. We might use our finger and point, This is what we want to do with our lips. Mom, in the mirror, and give them that mirror to have visual feedback. We might use things, because again, it's motor training, right? We might use things like tongue depressors. Like if they keep, I call it like if they have a lisp, for example, I call it like, oh, you have a sneaky S. He's trying to like slip out through your teeth. Like if they have a lisp, like a snake, like, oh, that S is sneaky. He's trying to escape. Gotta get it back, right? So you might use like a tongue depressor. Literally, I'll use a pen. And so now you're giving them like a physical cue, snake, to make sure that tongue doesn't escape, right? But you can use tongue depressors. You can use that with all different types of letters. But that's giving, now they're getting like this tactile cue, like feedback. Oh, my tongue is going too far forward. You can do something like sound shaping. So this is when you take a sound that they can already do and you progressively move it towards the sound that they want to make. So for example, if they can say a T, but not an S, you would start on the T, ta, 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 and start making it a squeakier T, ta, 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 and move it forward. Because the tongue placement, ta, is like on that, it's a stopped, and this is going to kind of test your awareness of those kind of like, IPA phonetic terms that we've been learning, like stops, velars, fricatives, right? So a T is a stopped alveolar sound, t, because your tongue is right there. That's your alveolar ridge. And you're going to slowly turn it into a fricative. and slowly let that air escape. Ta, 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 sa, sa, and gradually move it forward. There's a lot of ways you can do it. There's probably even better ways you can do it, but that's an example of how you would use a technique that's called sound shaping. Another thing that you need to do, this is a way of targeting speech sound disorders, but it's also, we would consider this type of consideration also in assessment. So we always want to, again, like I said in the last video for 530, we want to set the student up for success. So we want to start them where they can, maybe still can't do it or struggle a little bit, but can be the most chance of being successful. So if they have a really hard time saying a speech sound disorder, we want to start them off on that isolated letter. Just ta, 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 and get that repeated, because they might be saying like tha, tha, tha. Like, no, we're going to use our tongue depressor, move that tongue back, ta, 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 and have them do repeated trials just on that isolated sound word. Once they start being really consistent with that, I would say probably, moving up into the 60s, 70s, percent accuracy, kind of getting into the higher percentages. That's when we can start incorporating in the next stage, which would be syllables like tom, ta, toe, and just getting really like adding another vowel, but still keeping it very simplistic. When they start showing success there, we move to words: tom, talk, teach, tam, turn, and just give them the repeated drills, then into sentences, then into conversation. Interestingly, we don't, well, a lot of times, I don't know, a lot of you I know work in the schools, so we'll be looking for like 80% accuracy or 70% accuracy, and then once they achieve that goal, they're done. But interestingly, if they can do these speech sounds kind of spontaneously in conversation about like 50% of the time, that is actually when we're going to start looking for dismissal, because if they're to that level, that means it's going to probably continue to improve on its own. They have that kind of generative learning happening. And so we can start really be thinking, okay, they're really starting to get confident in their speech sounds, even if they're not 100% correct all the time. We already talked about using modeling and imitation. That's like using the mirror or using those motor mirror neurons for code talking. That really helps. Actually, surprisingly, it's really, really useful because we're using the brain to help us fix the brain. Visual and tactile feedback. That's a ta, 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 like kind of giving them those cues. And then drills and repetition. This is a motor-based disorder. So kind of like what I was saying, I know we're talking about the language course, but drills, repeat, because we're training that motor process. Okay, now phonological disorders. So we are still going to work on drills and repetition, but phonological disorders are different because instead of really nailing that motor ability to physically produce the sound, we're actually working on building their awareness, building their discrimination. Like, for example, one thing that you'll do is you will, I love my little super duper cards. I know I talked about that last time. Super duper cards. Just Google it. They have tons and tons of material resources if you're not already using them, but they just have so much handy dandy stuff they can pull right out of the closet. But one of their cards that they use for phonological disorders is they will have two different cards that they kind of like, for example, if they're doing cluster reduction, they're going to have a picture of, let's say they're shortening plane to pain, right? Well, a plane is something that flies in the sky. A pane is a window pane, something you see on a window. So they have pictures for each. And so now you're starting to cue them in. No, these are two different words. You can't just leave a letter out, right? That's silly. So we're saying plane. We didn't say window pane. That's a window pane. We're talking about a plane flying in the sky, making it silly and fun. But so that would be kind of like that minimal pair therapy where you kind of show them the difference between, another example is T versus key, right? So that would be like that setback sound, key, or T, front sound, t, t, t. So if they're backing and they're saying, oh, I would like to drink some key. Well, we can't drink a key. That's something that you use to open the door. You need to drink tea. T, t, t. So that's minimal paratherapy. I don't use this one very much. There's one called multiple opposition therapy. This is where you're kind of like working on several different, 3 or 4 different contrasting sounds kind of all at once. Do for go, show, toe, addressing all 3 sounds together. I do know there's value in it. It's just not something that I've used a lot. Instead, there's another one called maximal opposition therapy. And this is when you use like very different sounds to start working on like distinguishing features. And again, like this is a lot of information. This is more just kind of for building that awareness. This is all to kind of supplement your reading and supplement your worksheets, but I'm just kind of talking through this with you. So whereas key and T are very similar, you're just kind of moving that back tongue forward, right? Man, man, a bilabial, and fan into like kind of like a fricative interdental labial kind of position. That's kind of like a more oppositional therapy. The interesting thing with this is we've found that when you do kind of that maximal opposition therapy instead of the minimal pairs, you actually get more wide sweeping changes. What ends up happening is you start targeting multiple letter groups all at once. And there's something where you'll get like kind of, again, that kind of generative improvement. Things that you haven't targeted before will start to kind of fix themselves a little bit on their own. I mean, I wouldn't rely on that, but it's just kind of like a happy side effect for using this. And also we would use this more in that kind of like the more severe disorders where we really need to kind of get like a lot of gains. You would kind of use this maximal opposition therapy. And there's many more, but those are just some examples. Okay, let's see. Okay, so how to determine. We're looking at articulation, phonological, the difference between the two. So we would do a speech sample. Of course, like I said, and some of the other recent assignments, we always do standardized tests, especially anytime like insurance is involved or an IEP is involved, a school district is involved, we have to use standardized tests. But we could also do it through like, supplemental picture naming or conversations or having a quick chat. But you want that kind of speech sample because you can kind of see the types of mistakes that they're using. So, for example, we would never do just the Goldman-Fristow, which is kind of like testing for that, like, can they say the letters? We would never do that in isolation and then do nothing else because that's not going to be enough information. When I was working with my little preschoolers, might do like the Goldman-Fristow and the CAP, which is a phonological test. And because you want to test both, you want to test their articulation as well as their phonological processes. And you would also want to do just a little speech sample. And this is where I would record on my phone because you're not going to be able to write fast enough. And you're writing down exactly what they said, but also how they said it. So in this course, we're teaching you guys how to use IPA and diacritics. So that is the standardized method for how speech therapists you could type it, use it. It is consistently understood. I mean, granted, when you're out in the field, another SLP might need to refresh their knowledge on these symbols. But either way, it's generically understood. We understand it. It is a language that anybody can like see what symbols you're using. I'm not encouraging this, but I will say that sometimes when you're in the field, you might develop your own shorthand. That is fine if it's just for your own notes. So if you're going to do that, you just need to make sure, like in written text, you're describing exactly what you're hearing, or you're kind of translating that to IPA or diacritics. But I'm offering that up as a sample because it just might be quicker and easier in your mind when you're in the moment to kind of transcribe what you're hearing, and then you can go back and fix it later. But at the end of the day, you do want to transcribe exactly what they're saying and how they said it. So for example, if they said a T, right, and they said Tom, right? Well, it's still a T, but can you hear a little bit of that? Just a little bit of a squeaky T, like a little bit of Tom. Oh, Tom said that we could go do this. It's not Tom said we could go do this. It's just a little squeaky. So he has the T, but we would make a note of that, especially if we're seeing that as like a pattern, either for all T's or for other types of stopped sounds like duh, ta. So that's what I'm talking about. How did they say it? Yes, they had the T, but was it a little aerated? Was it almost kind of becoming a fricative? Like, what are we hearing? Let's see. When we talk about the different processes, if we start noticing that, every time they say a, sun becomes ton, this would be an atypical one, but fun. Let's say fun. I'm just got there. I can't come with that on the spot. But if you start noticing the recurring processes, that's when you would start to be like, you would stop and be like, ooh, I'm starting to hear that they're stopping these sounds like recurrently, and you'd get the different word examples that you're seeing. You would also consider frequency and impact. So not only is this just good to know from like an evaluative process, it is also often required for, again, either IDEA, IEP eligibility, or Medicaid billing, insurance billing. If it's minimal, if it's only happening 10% of the time, you're going to have a hard time convincing anybody to pay for that, to pay for fixing that, especially in the school districts, because we have to keep caseloads reasonable. One thing that I don't know if you guys are familiar with IDEA, our special education law, but there's a common saying that we're not promising a Mercedes, we're promising you a Ford, as in we will help you, but rightly so, they're considering bandwidth, caseloads, one SLP at a school, across the nation. So unfortunately, a lot of times that means those kind of mild kids don't really qualify. You're going to be looking more at the kind of moderate to severe kids. So really, you're going to be looking at, speech sound disorders happening 40% or more of the time. And again, that's not a qualifying number. Every state and school district kind of has their own little qualifying numbers, but I mean, if you're only seeing something 10 or 20% of the time, it's probably not going to be something that we're going to address in speech pathology services in the schools. Okay, let's see. Also, are they making multiple errors? Sometimes if they're maybe doing something like 35, 40% of the time, but it's just one error, depending on the school district, that might not, you might just get over the line of qualifying them. But if they have 2 or 3 sounds at 30% error or more, now we're starting to look at, being able to like kind of qualify them. Like, this is actually a problem. And another thing we consider is this, how else is this impacting them? Is it impacting them educationally, social? Don't forget, as SLPs, we can consider social impact. A lot of times we forget that. We think we can only consider academic impact. We can also consider social impact for eligibility, but definitely academics. Like, is it affecting them academically? Are they spelling things wrong because they have a speech sound disorder? But also we want to think about, like, yes, they're doing these disorders, but is it developmentally appropriate? For example, like, it's totally developmentally appropriate to not say R's correctly until 7 years old. I mean, obviously, we would hope to start seeing it sooner in some children development, much sooner. But really, especially in the schools, we can't really say it's wrong until they're 6 or 7. Another for phonological processes, we some things are age appropriate, like cluster reduction, kind of that plain or pain for plain, kind of reducing the amount of consonants that are jammed together. That is developmentally appropriate until age 4. So if we are kind of doing that little early intervention group and a 3-year-old is coming in and they're saying, I want to go to school today, we can't do anything about that because it very well could be developmentally appropriate and we won't really know until they're older. So that's a lot of the reason why too, if you're in the schools and you do have kind of like a head start or that preschool group, and a teacher refers you, really, really guide them. Use your kind of clinical judgment to say, okay, I know this kid probably does have articulation and phonological disorders, but they're 4. So let's shelf this referral until they're 5 and in kindergarten. Because if they're still making the same mistake, all of a sudden now, like their standard scores, which would have been much higher, that the standardized test is going to say, oh, this is within normal limits. The difference between 4 and 5, what they can't do at 4 and what they can't do at 5, now all of a sudden becomes moderate to severe. Like it really kind of jumps. So this is something that you will develop with practice the more you look at your tests and kind of like start to learn kind of the patterns, or you can even remember do that quick check, like when do letter sounds form, when do phonological processes go away. But just something, just back pocket for later clinical judgment. You can kind of help families and parents out, be like, your birthday's in 4 months. Can we wait 4 months to test? Because I think they're more likely to qualify if we wait. That kind of thing. Okay, let's see. So how this translates, so we're talking about like 40% of the time or more, or maybe in and around there or less if there's multiple disorders. But also we want to look at standardized scores. So that's that kind of SS. I know we've been talking about that in our recent discussion boards. But when you do the standardized assessment, you're going to get standardized, like standard deviations. So normally school districts, I know this, these numbers might seem very ethereal to you at the moment, unless you're assisting people, SLPs, with reports and reading reports, explaining it to parents. But the school districts are going to often require 1.5 to 2 standard deviations below the mean. So probably they're going to need to be like 7th percentile of children with these speech sounds or worse. Definitely when we start getting into the 5th percentile, the 2nd percentile, the 1st percentile, oh my gosh, yes, they're going to qualify. That's very severe. Okay, let's see what else. I think that's mostly it. And it's not mostly it. I just want to double check, making sure I'm not forgetting things. So, so going back to kind of like causes of speech sound disorders, we've talked a lot in this talk about articulation disorders and phonological disorders. Those are our main ones. Those are our most common ones. I want to say in my work in the schools, that's all I saw. I don't think I ever saw a child with childhood apraxia of speech. As you know, a lot of you guys did some work on this, very rare, but that's another possible cause of a speech sound disorder. Dysarthria, that's when they're going to have that kind of brain issue that is kind of systemically probably can just affect the mouth, but it's, probably affecting more things are going on, but that's that kind of muscle weakness. So they, might have the awareness, or if they really try hard, they can do the speech sound. It takes a lot of effort. So while they might be able to say, with you in therapy, when they're talking, it's just weaker, more imprecise, because it takes a lot of muscular effort for them. Like, so much, it's going to be like a little bit more, like just like weakness issue. And of course, anything structural or hearing related is gonna cause it, like a cleft palate, hearing loss. And then I know I just breezed over childhood apraxia of speech, but I think you guys have a pretty good concept of this as well. But this is when you're gonna have it's a severe motor planning articulation disorder, very inconsistent errors because it's actually a problem with the motor cortex and the motor planning. So that's why it is, it takes a lot of detailed and intricate repeated trials. A lot of times there's programs out there for systemically just building every single first position of C in 30 different words, every single first position, and just working your way through the alphabet, working your way through the vowels, because it is a brain-based motor planning disorder. Okay, let's see what else. I think we're doing pretty good here. Seeing if I'm missing anything. Okay, I'm going to go over this. This is from your textbook, but just kind of some clinical implications. So, we want to be able to summarize and classify articulation versus phonology, or a combination of the two. We haven't talked about that yet. It can be a combination of the two. So we always want to consider that as well. Like they truly might have a lisp, which is an articulation, or they can't say that dang S. But they might also have fronting and backing and all this kind of stuff. Let's see. So, but knowing these, whether it's an articulation or a phonology or a combination of the two, is going to help us pick the right approach. So that's why we always want to know the cause of things. My special interest is autism, so I always like to kind of use this as an example. But a child with ADHD and a child with autism might present similarly, but their reasons are different, right? Like a child with ADHD might have social issues because they're hyperactive and they can't focus and they can't remember what you're saying, and a child with autism might have social issues because they're kind of that social communication brain isn't working and they're kind of breaking down. So they still both have social issues, but they're for different causes. So it's the same with articulation and phonology. They're having trouble with their speech sound. Their intelligibility is poor. Great. Why? Is it that they can't make the sound, or is that as a rule-based phonological disorder? Because the treatments of the two different things are going to be very different. Okay, let's see. I think that's it. So last but not least, I know thank you for people who asked. I always try to, if you guys feel like you need something or some sort of support, especially for like pre-planning of an assignment or a test, I'm always within reason, I'm very happy to help. So I did have a few people ask for a midterm study guide, and so we made one. So you'll see an announcement on there about midterm study guides. So just review that. But I know in some of your assignments I said refer to page 48 of your textbook. Well, that really is important because that's going to be your IPA form, your diacritic, kind of cheat sheet, things you need to be really, really familiar with. They are, like on the test, there are questions for specific IPA and diacritic reading and use. So really, I know it's a lot of symbols, but just make sure you are ready for that. Really be aware, there was that one assignment where we did the manner, place, articulation, high, low, the difference between the vowels, initial, medial, final placement of vowels and consonants. Review that worksheet, and if maybe you feel like you didn't do well, just start doing work on that, start researching it, start using your textbook, because your textbook is going to have the most accurate terms for what we're looking for on the test. But if you find some good resources that align with what your textbook is saying, you can also do that. I would honestly just say review your assignments, because any worksheet that you did, any skill that they asked you to demonstrate, I think there was some like tricky things on what like the early definition worksheet, the difference between phones and phonetics and phonemes. They're all very similar. I would make sure you know all of these, the difference between those concepts, what they are, the features, what they sound like. If they were to describe it, would you be able to find it in a word? That kind of thing. Again, of course, as with anything, textbook, 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 review your main section, summaries, and vocabulary terms. There are some things on assessment, ethical and appropriate assessment practices, especially including maybe second language learners or diverse communities, dialects. Let's see. Remember, I know there was a couple of things we ran into on some assignments. When they talk about developmental milestones for this test, we're talking about speech, sound, developmental milestones. So what is the baby doing? What is the 1-year-old doing? When are these letters forming? What age? What are they sounding like? What's their placement? What's the anatomical what is happening anatomically as a child goes from infancy to early toddlerhood to preschool? How is that going to change how sound is made? Let's see. Phonological processes. Again, I gave you a few. We were talking about stopping, backing, fronting, final consonant deletion, cluster reduction, but there's many more. So make sure that, I think there's probably, I'm going to give you a false number, but just as a ballpark, let's say there's like 15 of them. I should probably know that, but at the top of my head, I forgot. So make sure you know the different phonological processes and what they are. And also, importantly, no, there is a difference. I think we ran into this in some of the assignments as well. There is a difference between what the phonological process is and the IPA term. So make sure you kind of at least delve into like kind of the difference between the two. So like pa, it's like a plosive, but we're stopping the ear. So it's a phonological process. It's stopping, right? So there's kind of like a little bit of the two. Let's see, review physiological development. And again, know those IPA terms versus the phonological terms. So it's a lot of information. These are starting to turn into medium-sized lectures as opposed to minis, but I'm sure some will be shorter than others some weeks. But again, this is supplemental resource for you guys. Hopefully this is helpful. And let me know if you guys have any questions. You guys are doing well. You got this. I turned it around this time, so it's not backwards. And stay in touch. Let me know if you have any questions. I'm always here for office hours, or if you guys need to schedule like a Zoom meeting one-on-one, I'm available as well. All right, thanks. Good luck.